Hello, this is a specimen of a kidney which has been longitudinally bisected, and we can see that there are several very obviously abnormal things. First of all, the kidney is markedly enlarged. The normal size of a kidney from the superior to the inferior pole is roughly about 11 to 12 centimeters. And if you look at this scale, this being the 10 centimeter mark, you can see that this kidney is enlarged. The second very obvious abnormality is the fact that the entire pelvic calyceal system is severely dilated. And this goes down to the proximal ureter. And actually the third abnormality is the fact that the renal parenchyma itself, the cortex and medulla, is markedly thinned and atrophic. Just to show you how thin the renal parenchyma is, in some areas it is almost as thin as 1 millimeter, and we can't also really readily appreciate the corticomedullary junction where the cortex stops and the renal medulla starts because of the severe parenchymal atrophy. This is the capsular surface, and some of the areas of parenchyma have been so thinned that this kidney is almost translucent. The diagnosis here is hydronephrosis, and hydronephrosis is often due to obstruction, and in fact we can see the cause of obstruction, which is a calculus in the proximal ureter. So let's do a quick recap on hydronephrosis. It is defined as dilatation of the renal pelvis and calyces, so this is a very important keyword, associated with progressive atrophy of the renal parenchyma, again important keyword here, atrophy, due to obstruction of the outflow of urine. So in this definition, we have what you expect to see in terms of the abnormality, both affecting the pelvic calyceal system and the renal parenchyma, and we also have the root cause. In terms of etiology, it is obstructive in nature, and if we think about it, the obstruction can be at several different anatomical levels. Moving from proximal to distal, it could be in the renal pelvis, in the ureters, in the bladder, and also at the level of the urethra, for example, with prostatic enlargement. And in terms of causes, we can look at several types of etiologies, for example, congenital conditions like posterior urethral valves, renal calculi, or even calculi anywhere along here, for example, in the ureter, as in this case, tumors, which can be intrinsic in the actual urogenital system or extrinsic, for example, intra-abdominal tumors or carcinoma of the uterine cervix that can compress on the ureter. Inflammation can also give rise to swelling, edema, and obstruction and strictures, and there can be sloughed material like blood or necrotic renal papillae, which can fall into the ureters and cause obstruction. And finally, there may also be functional causes of obstruction, such as neurogenic obstruction, perhaps as a result of spinal cord damage. Clinically, if the obstruction is acute, this can give rise to pain because it can cause stretching of the renal capsule, but at the same time, it depends on the cause. For example, a calculus would cause very severe colicky abdominal pain. In chronic hydronephrosis, the renal function can actually be maintained for quite a while until it actually gets compromised, and eventually the kidney is unable to concentrate urine, and this can give rise to polyuria and nocturia. So to summarize, here is an example of a case of hydronephrosis or hydronephrotic kidney with marked dilatation of the pelvic calyceal system, marked atrophy of the renal parenchyma, and we have the cause here, which is a calculus in the proximal ureter.